This conference will now be recorded.
So what is your comment about the base axis? What is the normal base axis? Any idea? Can anybody say? Yes, ఏదో ఒకటి చెప్పండి పర్లేదు రాంగైనా. What should be the normal base axis? Plus or minus 2. Okay. So ఇక్కడ 7 ఉందంటే base axis elevated. So this is how you analyze it. 0.35 slightly acid. 3.4 is actually supposed to be. Respiratory changes as a PCO2 is elevated. That means whenever the PCO2 is elevated, so it is the component is respiratory. If the PCO2 and pH are not going together, then you have to think of metabolic. Metabolic change enti, what is this alkaline? So normal is 2, base axis is 7. That means plus 5. Then 2 plus 5 ayindi. That means base is increasing. So it is an alkaline. So what has happened is respiratory component is causing acidosis. All base compound is trying to neutralize it. So it is called as a compensatory base axis. This is a compensatory. Whenever you take the first one as a base, the second one is a reaction. So respiratory acidosis usually normal is 40 kada? Normal is 40 millimeters of mercury. So how much it is excess? 20 millimeters of mercury excess actually. PCO2. So to complete the balance, plus 20 should be required. For each 5 milli, there is a 3 is the 3 is to 5 is the change actually. So base axis is 12 aval asalaithe. Then it can balance this acidosis. Because for each rise of 5 millimeters of mercury, the base axis will increase by 3 points. So for 20 points, the 3 by 5 is 12 millimeters of mercury was there, it will be component. But actually here only 5 vachindi. So that means it is a partial compensation. That's how you read it actually. Base axis is 7 milliequivalents. So it is halfway between the 0 and 12. That is a typical of a metabolic compensation. You always, metabolic compensation is never complete. Remember, metabolic tries to balance it, but it will never be same. The range is about 6 milliequivalents wide. In this example, between 3 and 9 kabatti madhyalo undi kabatti is okay. So this is how you read it. So we'll come to the actual class now. That's how you read. All of you are familiar with this. Just quickly I go through that because it's only revision class. You all know how acids and bases are formed. See, the normal HAN concentration is so many zeros followed by 7 zeros followed by 4 millimoles. So since it is very impractical to deal with the day-to-day discussions, we have taken the pH value. So instead of saying 40 nanomoles, it is a negative logarithm of the 0.4 is equal to 3.5 to 4.5 is a normal range of pH. You can see here. So from a neutral level, that is 3.5 to 7.5, if you take is normal. Any reduction below this is towards the acid side. Any excess is towards the alkaline side base. So acidosis associated with the clinical symptoms, it is acidosis. It's a venous blood. So anything associated with the symptoms with elevated pH is called as a alkalosis. The maximum tolerable limits 6.8 below the death acidosis, and pH above 8 is not compatible with the life death. So this is the pH range if you see. You know the mechanism, all of you know how these things are formed. I'm not going first deep into this one. Already you are familiar. I don't want to waste time here. The acid is formed. Most of the acids are carbohydrate in the fat metabolism. Okay. Very little metabolic acid produced. It is eliminated by the kidney. So mostly in the respiratory and to some extent kidney, as far as the acids are concerned. Whereas bases are concerned, they are from the metabolism of amino acid metabolism, especially the glutamate and aspartate. So when they get oxidated, they can form organic anions, lactate and citrate, and bicarbonate. So this is how the bases are formed in the body. Now it all depends upon the balancing these two. See, you can see the acid and base balance is the in between. What is balancing day to day is this one, buffer base. Okay. How is this acidosis? One is metabolism is producing these substances. Output is through lungs and kidneys. We have two organs to balance, to excretion side. And maintenance part is looked after by the body buffer systems. These are the basic three tripod of the acid-base balance. It's like just like primary problem. When there is a primary problem, the secondary can't try to come. For example, with the respiratory problem, the kidney tries to prevent it. Metabolic compensation. The metabolic problem, respiratory helps you compensate it actually. So when this compensation tug of war is falling one side, so the problem comes actually. The respiratory acidosis is full. Here, nobody is crossing the limit you see here. So if for some reason the pull is more on that side, respiratory is dominating this, metabolic acidosis could not compensate. This is a respiratory acidosis, attempted metabolic acidosis. Like that is a diagrammatic explanation. So now here in this table, we can understand in respiratory acidosis, what will the plasma pH is increased or decreased? Come on. What will be the pH in acidosis? Anybody?
Decrease.
Acidosis, amma. So it is decreased. Low. Here the primary is respiratory because of the decreased because of the accumulation of the carbon dioxide. So what could be the compensation here? Ela compensate chestam. Suppose we can increase the bicarbonate. Can we increase the bicarbonate? By stopping elimination of the bicarbonate, you can compensate. So the kidney tries to increase net, either by increased renal net acid excretion, okay, tries to increase more hydrogen ion, or conserving, increasing in the serum bicarbonate. So these are the two compensatory mechanisms. That's how we must understand. For example, the opposite, respiratory alkalosis. pH will increase. The pH is increased. So this is because of the decreased respiratory PCO2, because washout. PCO2 instead of 40, it is coming down to 20, 30, 20, whatever it is. So how it can be compensated? This opposite of this above things. So conservation of the net acids from the renal or increasing the bicarbonate excretion. So these are the compensatory mechanisms are decrease in renal net acid excretion, decrease in the serum bicarbonate. So these are the usually compensatory mechanism. If you understand this balancing, so now coming to the metabolic acidosis, just opposite. Why is the metabolic acidosis? Acidosis pH naturally, whenever you say acidosis, pH is increased or decreased?
Decreased.
Low. This low is because of the low bicarbonate. Bicarbonate is lost actually. Decrease in bicarbonate is the cause. Here it is an increase in PCO2. It is decrease in bicarbonate. So how is it compensated? The lungs, respiration tries to conserve more of it. Instead of acidosis means you can just throw away most of carbon dioxide. So by increasing the respiratory rate, small respiration, all of you know hyperventilation. So you try to throw away more carbon dioxide. That's why you may compensate for this actually. That is the respiratory compensation. Opposite of this is metabolic alkalosis. What happens here? The pH is elevated. Okay. And this elevation because of the increase in bicarbonate, not because of the respiratory washout. And how does the respiratory compensate it? By stopping the elimination of the carbon dioxide. It tries to conserve it, maybe decreasing the respiratory rate or something like that. So hypoventilation, so that carbon dioxide is preserved in the body. So these are the just compensatory mechanisms you must understand. Now we come to the specific disorders. The first and foremost you will see what is called the respiratory acidemia. We must understand this terminology. Acidemia and alkalemia tells us what is in the blood only. It doesn't say about the clinical condition. An abnormal process which decreases the pH and increase in acid or decrease in alkali. These pH changes can happen either way. If you decrease the alkali, pH can go changes to negative side, and increase the acid also, pH goes down. So either of them produce the result is same. Only thing is alkali reduction is a metabolic process, acidosis is a respiratory process. The opposite is alkalemia. That means blood is alkaline, about 3.5, 7.35, either because of the decrease in hydrogen ion concentration or increase in bicarbonate. Now coming to the what you previously described is acidemia and alkalemia. The difference with the acidosis and alkalosis is not just abnormal changes in the blood, but also the process. What has caused this? So this process is also important covered here actually. So abnormal process or a disease which reduces cause. That is when you accept this acidosis is a symptoms and disease together. Alkalemia is only blood changes. That is the difference. Okay. Same alkalosis means, sorry, it is IS. Abnormal process or disease which increases or pH or decreases acid and resulting in the symptoms of the disease. Now, this is the anatomy of a ABG report. Before you go into that, actually, when you go to the ICUs and get the ABG report, this is how you get a report. So, on-so diagnostic, blood sample, report dated, so on so. So here, you must understand before you read it actually, just like reading ECG, this is also very important for a clinician to understand. So how do you read it, this one? First one is measured values. There are some values are measured values. So these measured values are these one, pH, PCO2 and PO2. If there is corrections, actually these are sometimes their corrected values are there. Most often you don't bother about this actually. Okay. Sorry. These values are correct, calculated data. Bicarbonate, actual bicarbonate, standard bicarbonate, these are computer calculates them. For your practical purposes, don't bother about the standard bicarbonate. We'll see only the measured bicarbonate. Okay. And the temperature, these data we feed actually. When we take the ABG, we have to feed this thing whether the patient is getting any, because it's not an atmospheric air, he's getting 30% oxygen. So FiO2, how much temperature, body temperature, what was hemoglobin at that day, you have to be feed it actually, so that the calculation becomes easy. This is how it is a ABG report looks. So whenever we get an ABG report, these are the steps you follow. What is the clinical situation? Because always you must do not depend upon any of the just results alone. So what is the clinical condition? You always take which condition is, because that itself will explain whether the patient came with a severe diarrhea or vomiting or altered sensorium convulsions. So whether it is a uremia or it is a hepatic coma or all those things, the antecedent history will give you some idea. And coming to the report, first read the pH. Is it normal or toward the acidosis side or alkalemic side? If it is abnormal, and who is the culprit? That means, is it a respiratory problem or a metabolic problem? As I said, how do you know? The carbon dioxide PCO2 is elevated, it is a respiratory problem. So bicarbonate is diminished, it is a changing, it is a metabolic problem. That's why these two things you have to read. So whenever you get this, so what you have to do is PCO2. So this is a PCO2, sorry, measured one. This is more important, PCO2, and bicarbonate is always actual bicarbonate only. You read actual bicarbonate, that's all. So this thing. So this is for the respiratory, and this will give metabolic. So these measurements will give you what is it. Then if it is respiratory, you have to also this acute or chronic. So that depends on any from the history itself you may know. Apart from that, from the lab report also you can just assess it. Then if see whether any compensatory is going on, because that is comparing the bicarbonate values and the proportions are there. At least at this level you understand always there is a chance of compensatory mechanisms are there. So that's why you see as expected bicarbonate values for a given carbon dioxide or expected carbon dioxide for a given bicarbonate is there or not, understand. So you calculate from the proportions whether there is any compensate is going on now. When it is a metabolic, then you have to measure the anion gap. Is it because there are certain conditions anion gap is increased or decreased? Then if ultimately you must see whether there is a multiple systems, because there is a always combined acidosis and alkalosis, not a compensatory but actually contributory. So such things you must understand. Okay, then that much conditions where you cause a respiratory acidosis. Which conditions can cause respiratory acidosis? The most common cause of acid-base balance, as far as we are concerned, it is the most common one. This happens with a shallow breathing. The gas exchange is hampered either because of disease, because of the, for example, you take example pneumonia. What happened? It is a consolidation. So gas exchange is happening inside the alveoli. If the alveoli is filled with some exudates or actually consolidated, there is no chance of exchange of gases. So that is the reason. Cystic fibrosis, again, too much of fluids, actually secretions blocking it. Emphysema, they actually exchange surface itself is destroyed because alveoli have been coalesced. So these are the conditions which may produce acidosis, especially as a chronic condition, I know. So it may be acute conditions where there is a sudden elevation of the above the upper limit, that is above 45, and there is an acidemia, pH falling below 3.5. What happens in chronic is it is elevated above upper limit, okay, PCO2, and pH is not elevated, is not decreased as much as this one. Here fall is very clear. Whereas in chronic, pH is maybe normal also. Only thing is PCO2 elevation you see may be normal. So that's such a situation you come across in a chronic acidosis because there are compensatory mechanisms slowly. Renal compensation comes slow, but it's a chronic process. So when the bicarbonate is rising even above 30 millimeters, the pH may tend to be normal. So you have to be very careful in noticing the values. What card is it? So in acute, PCO2 is elevated above upper limit, that is above 45, and accompanied same thing actually. So the same thing I have to repeat slide actually. We'll go to that. Which conditions cause this one? Acute means there is an abrupt failure of the ventilation. So the PCO2 has it. For example, all the causes of respiratory may be secondary to CNS depression. So patient has gone into coma or acute traumatic brain injury. Brainstem injury, especially the respiratory centers are situated in the brainstem, all of you know. So if there is an injury to the brainstem, then he will stop breathing actually. So brain is all right. The musculoskeletal system, so even if there is the muscles of respiration have failed, for example, Guillain-Barré syndrome or myasthenia gravis, so they are not able to, the diaphragm is not able to move, the chest is not able to expand. Such situations, there cannot be any gas exchange at all. So these two are okay, but the airway, there is an obstruction. So obstructive air diseases like bronchial asthma or a foreign body, laryngeal edema, pulmonary embolism. Just you think of these causes only because 1, 2, 3. The inside conditions you need not have to mug up actually. These things you can think of. No, one is actually brain itself is fault. What are the conditions can produce a respiratory center failure that is in the midbrain, that is a medulla, that is brainstem, and if there is a CNS, entire CNS is depressed, convulsion, post convulsions like that. So if you think of a musculoskeletal, you can just imagine automatically what the muscle paralysis are there. Actually, so many muscle paralytic conditions, actually muscular dystrophies, GB ganglion berry, poliomyelitis, bulbar palsies, pseudobulbar palsies, all these things you can think of. Whereas obstructive lung diseases, so starting from the trachea to the alveoli, what are all the things actually? So if it is filled with lung fluid, pulmonary edema. If it is a foreign body, or is a pulmonary embolism, bronchial asthma, chronic obstructive COPD. So for conditions thinking is much easier. All this may be drug induced. There is only thing is you have to remember drug induced. Something actually sedatives act on the central nervous system. Barbiturate, these are also central nervous system depression. This depression or CNS depression can be disease oriented or drug oriented. So drugs can cause and diseases also can cause CNS depression. That's why you can put the drugs here also, no problem. So these are the conditions for the acute respiratory failure. So COPD is a chronic disease. Actually, this is a chronic. That's why they didn't mention it there. So as the name itself goes, C chronic obstructive pulmonary disease. So obesity hypoventilation syndrome, this Pickwick and all of you know the sleep apnea. So over the course of the time, grow slowly, they cannot sleep, and while going to sleep, actually they stop breathing. That is obesity hypoventilation syndrome or Pickwick syndrome, it is called. Any neuromuscular disorders, amyotrophic lateral sclerosis, the muscles of the respiratory gradually fail over the course of time. These are all chronic conditions. Severe restrictive respiratory, in the local causes, respiratory causes, these are thoracic deformities, interstitial fibrosis. Interstitial fibrosis may be secondary to very viral pneumonias or actually now COVID disease, all such things actually over the course of that. Those patients who recover from the COVID also going for intestinal fibrosis eventually. So these are the conditions over the course. We have fungal infections are actually pneumoconiasis. All these things can produce interstitial fibrosis. This happens over a long course of day. That's why we call it a chronic condition. That's all. So whatever it is, so this is the Pickwick syndrome. If you remember the from Shakespeare, Pickwick, the obese person. So we're actually going on to this thing. So how do you calculate? Actually, this part maybe not so important. So only thing is the change in the pH over the for a given delta pH is how much change has happened. The fall in pH is equal to, you can calculate the percentage. pH fall, expected pH fall is 0.8 into PCO2 minus 40. 40 is taken as a normal. PCO2 minus 40 is equal to delta PCO2. It is called, this is called delta PCO2 is nothing but this one. So change in the PCO2, if this change you multiply with 0.8, if it is tallies with your pH, it is an acute. So if it tallies with 0.3, that means that is much lesser change, gradually. So it is a chronic PCO2. That means existing pH, usually you calculate from this PCO2 minus 40 into whether it is equaling 0.8 or 0.3. That is how you do it. So if it is in between, it is between the acute or chronic. Acute and chronic means between these two figures, you can call it as acute and chronic. This is how you have to see whether it is acute respiratory acidosis or chronic. So this is the changes I have been telling, just multiplication of the ratios, how you calculate, just for it. But how do they manifest? Symptoms are shortness of breath, easily getting tired, chronic cough or wheezing. When it is too severe, confusion, irritability, lethargy may be there. What is the treatment? For most of the conditions, you just very thing, treat the cause. See, respiratory acidosis, there is no quick formula. Just this is the one treatment, this is the drug of choice for that action, nothing like that. So you have to, etiology analysis is very important. So treatment is nothing but treat the cause. If it is central depression, attend for that. If it is a peripheral one, so see what you can treat. There is a COPD, management of COPD. If it is a bronchial asthma, treatment of asthma, like that. So ultimate purpose is you improve the alveolar exchange. If you fail in all these things, the last is assisted ventilation. Only thing is because in red letters, remember you never give bicarbonate in case of respiratory acidosis. Actually, it will worsen because the bicarbonate you have given is converted into CO2 and increases the PCO2 actually again burden, increases the burden. Never, never, never give bicarbonate in respiratory acidosis. Please remember this one. As an undergraduate, most of you are asked what is the treatment of acidosis means, respiratory acidosis. Never give bicarbonate. You have to write that clearly. So in block letters, do not give bicarbonate for respiratory acidosis. That's it. The next condition we can think of is respiratory alkalosis. So what is alkalosis? Is here this can be by rapidly breathing. Suppose if you go on washing out your carbon dioxide, this happens in very high temperatures actually. Or in hysterical patients, they keep on breathing themselves. It can be iatrogenic in our case. We don't know if you're giving a positive pressure ventilation or if your ventilator is set up at a higher rate than really required by accidentally. So these are the common causes. Some drugs can produce salicylates, especially in early stages, produce an alkalosis. Later on, it becomes metabolic acidosis. So early stage respiratory alkalosis, later stage metabolic acidosis. Salicylates produce a mixed picture. Please remember that is a specialty of the acetyl salicylic acid. Again, interstitial lung disease can cause just respiratory acidosis, as we thought actually previously. It can cause alkalosis also. Liver failure can lead to rapid breathing. Anxiety again through rapid breathing. Gram-negative septicemias, again rapid breathing. Hypoxia and severe anemia of high altitudes. So this can also produce. These are some of the conditions also. Think of conditions where you tend to breathe more. So with the examination tension or fear, liver hysteria, alkalosis, sometimes liver failure. These are the condition drugs. So you see the etiology. How do they manifest? So the most common symptomatology is the tingling and numbness. This is because of the fall in the serum calcium, which happens automatically with the alkalosis. So paresthesia, tingling, the sensation, nothing but the same as that one. Lethargy, and in extreme stages is the tetany. Once the calcium falls, serum ionized calcium falls, tetany lead to unconsciousness because this is the vasospasm of the cerebral vessels, and hypercapnia also produces some sort of a cerebral depression. Is it a protective mechanism? So these are the mechanisms. Actually, the symptoms are tingling and numbness and tetany, ultimately loss of consciousness. Then again, the treatment is simple. So you cannot, there is no one-point treatment for the respiratory alkalosis. Always look for the cause and attend to it actually. So simple as that. So in the examinations, whenever students write, treat the cause, even for any conditions, we cannot say no because answer technically is correct. So here, actually, it is there is the only answer actually, don't worry. Now, next condition is metabolic acidosis. Here, the hydrogen ion load, the acid load is increased or fall in the bicarbonate. Either way. So it is metabolic acids increase also can cause or fall in the bicarbonate, both lead. So all of you know, this is a Gamble-Graham they called it actually. It's one. So all the ions in the blood are divided into the anions and cations. So if you take the serum, the major ion is the sodium. So, okay. And anions, serum albumin, all the serum proteins are all negatively charged actually. So they are anion. There is bicarbonate and the chloride. These are the major. So if the sum of the anions and sum of the cations should be always equal automatically. So if you calculate this, sodium minus chloride and bicarbonate, this is being the major one. So remaining one is This is the compensate. This anion gap we call it as actually. So the proportionally change, actually here the chloride has increased, the bicarbonate has shrunk here, smaller one. See, because of the increase in chloride, the chloride has increased, you see. This situation is called as a no anion gap. So between the anions, chloride and bicarbonate, the major chlorides only we have taken. So this is a cation. So subtract this sum of the known anions from the sodium. So that gap is called as the anion gap. Here the no anion gap acidosis. Here actually there may be acidosis, but the anion gap is proportional. Whereas in this condition, high anion gap is if you chloride and bicarbonate, you have subtracted from the sodium, but still some gap is there. So that gap you mean to say there is something else is coming there. This is called as a unknown anions. That is anion gap metabolic acidosis. We'll come to more detail about that one later on. Okay. So this is how whenever you think of a metabolic acidosis, you have to determine whether it is an anion gap metabolic acidosis or non-anion gap. So this is how you calculate this. So usually chloride and bicarbonate, you know the serum sodium, let us say average 40, potassium is only 5. So 105 the chloride, bicarbonate is approximately 20. So normal anion gap, if you remove, subtract how much it has come, usually is 8 plus or minus 2. That is 10 or 12. 10 or 6 to, this is actually 6 to 10. Adults up to 12 plus or minus 2 means 10 to 14. So these are the ranges of normal. So anything more than this gap, that means some other anions are there in the body. That's an indication. So metabolic acidosis with anion gap. This is unmeasured anions are there. All of you know the formula, the mnemonic for this is mud piles. So what is mud piles means? Methanol poisoning, uremia, diabetic acidosis, ketoacidosis, paraldehyde poisoning, infections, lactic acidosis, ethylene glycol, salicylate. As I said, salicylate in the later stages produce metabolic acidosis. Early stages, respiratory alkalosis. So it is a shortcut is mud piles. All of you remember this mud piles. If you remember this, you can produce the remaining things. What are the causes of the metabolic acidosis? So loss of bicarbonate also, we said not only rise in the acidosis or external acid infusion. What happens in GI losses? Bicarbonate is lost. Severe diarrhea means what happens is the intestinal secretions contains bicarbonate. So if it is morely vomiting, so the acid is lost. If it is mostly diarrhea, bicarbonate is lost. That's why metabolic acidosis because of the bicarbonate loss. Or the losses may be through renal. The commonest one, renal tubular acidosis, toxins on the kidney, carbonic anhydrase inhibitors like and ureteral diversion conditions. As a compensator for the respiratory acidosis, the body's only reaction. Infusion of the hydrochloride, ammonium chloride infusion, maybe because of therapeutic conditions. Total parenteral nutrition. Some of the conditions where there is a possibility of acidosis can happen is these are the ones. There's very few conditions. Actually, this is a quiz question many times in quizzes. Usually we think of anion gap, no anion gap or anion gap metabolic acidosis. There are conditions, decreased anion gap metabolic acidosis, hypoalbuminemia, increase in potassium or calcium or magnesium in the body, or lithium toxicity. So these are the, usually we keep it for the quiz. Here, anion gap is decreased, very unusual actually, very rare things. How do they manifest? Clinical manifestation, again, the rapid breathing occurs because of the respiration is trying to compensate for the acidosis. They want to wash out more carbon dioxide. So that is called the Kussmaul respiration. All of you know, deep sighing, breathing, deep rapid breathing with sometimes fetus hepaticus, especially hepatic coma. There will be peripheral vasodilatation and shock, impaired cardiac function develops, lethargy and drowsiness and confusion in the later stages, hyperkalemia. We'll see how the hyperkalemia develops later. Non-specific symptoms like nausea and vomiting. In chronic acidosis, a gradually calcium loss is there. Calcium carbonate is lost in the bone resorption occurs. And muscle weakness develops because of the loss of glutamine from the body. So these are the conditions of the clinical features of acidosis. And how do you manage? Again, attend the principal cause. Bring the pH and around above 7.25 always, because 7.2 below is very dangerous. So because the cardiac contractility and responsiveness to catecholamines, this suffers below 7.2. That's why, so for making the body respond to medications, it should be above 7.25. Here, metabolic acidosis, you can give soda bicarbonate. Sodium bicarbonate comes in the metabolic acidosis management. Dose is 1 to 2 milliequivalent per kg. So remember, what is available in our dispensaries is 7.5% soda bicarbonate. This each 1 ml is equal to almost 1 milliequivalent, that is 0.9. Just 1 ml is equal to 1 milliequivalent approximately. Remember, that is easy. And this is a very high concentrated one. Never give soda bicarb intravenously directly because it is a highly concentrated one. Whenever you give soda bicarb, you have to dilute it as when you give as a bolus with equal volumes of a normal saline or a dextrose to equal volumes. Then it becomes nearly half of it you can give it. And avoid extravasation. You should not go be outside the venal. It will cause a severe necrosis, even it diluted also. So soda bicarbonate, you must ensure the cannula is right inside the vein. So this is a formula which you can 0.3 into base excess and all this. Based on this, usually when you come to the house agency, it's necessary. Whatever the deficit is there, half as a bolus, half as an infusion over 20. So when you give bolus, this is what I said, actually dilute equal volumes. Bolus means you can add with the intravenous fluid, the remaining calculate the fluid level. That's it. So if there is a volume depletion, because then what happens in the diarrhea, you replace it. If it is a diabetic ketoacidosis, you have to give IV insulin. And if it is a uremia, you have to go for the dialysis. If it is a poisoning, you have to go for dialysis. If it is a congestive heart failure, beware of it. Don't replace fluid very fast. You have to be very careful. And if it is a trimethoxamine, trihexyl methylamine aminomethane, this is called the THAM for the acidosis. Actually, it's not available in India. It can be used in case of a acidosis, especially because of the cardiac failure conditions. So as I said, the carbonic anhydrase inhibitors, poisoning, acetozylamide poisoning, you have to replace potassium. Serum potassium should be above 3.5. And in case of hypoadrenal state, that is a shock, Addison's crisis, all these conditions, you have to go for the steroids. The role of steroids come in the management of metabolic acidosis only in these conditions. So this is what I was telling. Hyperkalemia causes a shift of potassium into the cell, and compensatory hydrogen ion is coming from this inside the cell into the serum. So what happened? Acidosis has developed. So this is how whenever there is a potassium is increased, it goes into the cell, and what is as a compensator, hydrogen ions from the inside the cell come into the serum. So this produces acidosis. So this is the cause for the acidosis. Always acidosis and so hyperkalemia causing acidosis. We will see how there is second one, acidosis causing hyperkalemia. So suppose there is acidosis has happened. So the hydrogen ion go into the excess hydrogen ion go into the cell, and to compensate them, the potassium comes out of the cell into the blood. So whenever there is an acidosis of any reason, the serum potassium levels may be very much elevated. So the potassium has come out into this, and hydrogen has come into from that. So these are going hand in hand. Hyperkalemia causes acidosis, acidosis causes hyperkalemia. Please remember they are hand in hand. The next one, we have to deal with the metabolic alkalosis. Metabolic alkalosis is a extracellular pH elevation above 7.5, primary increase in the plasma bicarbonate. It's a very dangerous condition actually. The shift of, because oxygen dissociation curve shifts to the left. If you remember Bohr's curve, what happens if the oxygen dissociation curve is left? Because the tissue oxygenation suffers. The oxygen doesn't leave hemoglobin. It remains inside the hemoglobin only. So what happens? All the tissues suffer from this severe hypoxia. So because the shift to left of the oxygen dissociation curve is a very dangerous phenomenon. So it causes vasoconstriction of all vessels except pulmonary circulation. Ventilation is suppressed and decrease in ionized calcium and shift of potassium inside the cell. This is the opposite of a metabolic acidosis. Here, their metabolic acidosis, potassium is shifted from the inside the cell into the blood. Here, the potassium is shifted from inside the serum into the cell. So it will produce a hypokalemia and also loss of calcium. So broadly, metabolic alkalosis of two types. One is chloride responsive, the second is chloride resistant. So what is most important is what has caused alkalosis and what is it maintaining, because all the body has maintenance, all the compensatory mechanisms for this. Why is respiratory compensation not happening? So what is preventing the kidney from trying to excrete extra alkali? These factors you must always assume, because for alkalosis, metabolic alkalosis development, there must be severe kidney failure. So the first one, chloride responsive. Usually, how do you know it is? The urinary chloride is less than 15 milli equivalents. So such conditions are called as an chloride responsive. Examples are severe gastric losses. For example, if you are aspirating or pyloric stenosis, there is a only gastric secretions are being aspirated. Severe emesis, vomiting, or an astrogastric secretion for the preparation of for surgery or whatever it is. Thiazide and loop diuretics, which is alluretic drugs. Chloride losing diarrhea. So body chloride is lost. Low chloride formula when you are giving a artificial milks. And cystic fibrosis, where the sodium is lost through the sweat, like excess loss of sodium and chloride through the other than kidney body. So these are the conditions producing a alkalosis can be produced, and this is example of a chloride responsive. So whenever you come across a metabolic alkalosis, you decide it is a chloride responsive or chloride resistant. As I said, these are the conditions producing chloride responsive. Chloride resistant, again you have to divide into two halves. One is with increased blood pressure, with normal blood pressure. So conditions, example for increased blood pressure are renal adenomas, 11-hydroxydeficiency, 17-hydroxydeficiency, Cushing syndrome, Liddle syndrome, renin secreting tumors. These are all the conditions where the blood pressure is elevated. Whereas some other conditions like Bartter-Gilkey-Tillman syndrome and yeast syndrome, where the epilepsy, ataxia, sensory neural hearing loss, and tubulopathy. So these are the conditions where the blood pressure is normal. So when you're considering what is maintaining that, is it a chloride responsive or not? Yes, that there is a potassium deficiency, they won't respond actually unless you treat it. Is it a chloride is actually lost? Increased mineralocorticoid, chloride resistant is there. These are things you have to consider. As I said, whenever there is a alkalosis, hydrogen ion is compensatory response, but inside the cell, the hydrogen ion come into this one. So when the hydrogen ion has come into this one, it trying to correct acid-base balance. Alkalosis has happened. What happened is the potassium, you see, whenever the hydrogen is coming out and compensate the bicarbonate, the potassium, extracellular fluid, what little potassium is there, it is going inside this potassium cell. So relatively, there is a hypokalemia has happened. So this happens, hypokalemia cause. How do you manage metabolic alkalosis? Identify the cause, Mild to moderate, they're self-limiting. If there is a volume depletion, you replace it with normal isotonic fluids. If it is a carbonic acid anhydrous inhibitors, change the diuretics into the other type of diuretics. Ammonium chloride and arginine chloride can be medications, formulations you can give in a resistant case of massive gastric losses. If there is a potassium replacement, may be necessary if the hypokalemia is there, and peritoneal dialysis or hemodialysis in severe cases of alkalosis. The last condition is a mixed acid-base disturbances. So respiratory acidosis plus metabolic acidosis. Respiratory acidosis plus metabolic alkalosis also can happen. Excessive diuretic therapy, chronic respiratory acidosis with congestive cardiac failure. This is entirely growing in a different mechanism, not a compensatory. It is developing automatically separately. Metabolic acidosis with respiratory acidosis in heart failure, CNS depression, barbiturate poisoning happen. Metabolic acidosis with respiratory alkalosis, not as a compensatory. It is a separate disease, bronchopneumonia with high fever. So these are the conditions of called as mixed acid-base disturbances. Bronchopneumonia with high fever, phenobarbital poisoning, all these things actually. These are some of the examples. So to conclude, acid-base homeostasis is a dynamic process. Buffers are the first line defense. When they fail, buffers are by far the most important. Other organs involved are lungs, kidneys, and liver in balance. So that much. Okay. With this, I'll stop. Next class is there, I think. Thank you very much, Emma.